Okay, welcome everyone and good afternoon. I am Erica Narducci from Cancer Support Community Delaware. We are live streaming to Facebook. We also have a few people with us in attendance on Zoom. We ask you to just stay muted during the presentation. We are going to have a time for questions at the end. At any time, if you want to put a question in the chat or in the comment section, if you're on Facebook, I will be reading those when we get to that point. So just a quick introduction, if you're not familiar with Cancer Support Community Delaware, we provide emotional support groups, healthy lifestyle classes, and educational programs like this one at no cost to our participants. We have been open for over 28 years, and we are located in all counties of Delaware. So I am in Wilmington today. We have an office also in Kent County as well as Sussex County. And I am very excited today for our program. Welcome to Hereditary Cancer Genetic Testing 101. We are doing this in collaboration with the Vassar Center for BRCA, the Vassar Center for BRCA at Penn Medicine's Abramson Cancer Center is the first comprehensive center for the research, treatment, and prevention of BRCA-related cancers. These hereditary mutations affect both men and women and can be passed down from either parent. BRCA mutations can increase lifetime risk for cancers including breast, ovarian, pancreatic, prostate, and melanoma. The Vassar Center has genetic counselors who can help you learn more about hereditary cancer risk. And for more information, you can go to their website, which is www.vasser.org. And I will put that in the chat. I'll also put it in Facebook in the comment section. So now, with no further ado, I'd like to introduce our esteemed speaker, Jackie Cappadocia. Jackie is a hereditary cancer genetic counselor and works as part of the McDonald Cancer Risk Evaluation Center, sorry, it's a mouthful, and the Vassar Center for BRCA at Penn Medicine. She's originally from Toronto, Canada, but has lived in the Philadelphia area since 2013. She graduated from Villanova University in 2017 with a Bachelor of Science degree. Jackie then attended graduate school at the University of Pennsylvania, where she earned a master's degree in genetic counseling. She was the 2020 recipient of the Marie Barr Genetic Counseling Award. So thank you for joining us today, Jackie, and I'll turn it over to you.
Thank you so much, Erica, for the introduction. And hello, everyone. I'm so excited to be joining you this afternoon. As previously mentioned, my name is Jackie, and I'm a genetic counselor at Penn Medicine's Cancer Risk Evaluation Program and at the Vassar Center for BRCA. And I'm thrilled to be talking with you today about hereditary cancer genetic testing. And give me one moment to get the slides started. All right, perfect. So my talk today will cover off the genetic basis of cancer, as well as the importance of family history. We'll then review who's an ideal candidate for genetic testing, as well as what genetic testing actually entails. Finally, we'll review what to do if you have a positive test result, and I'll provide you with some resources in order to get connected with a genetic counselor if you think that genetic testing might be right for you. And then lastly, I will summarize the major takeaways of this presentation. So if nothing else, pay attention to that last slide. So starting with the genetic basis of cancer. So the genetics of cancer is something that's actually quite complex, but ultimately we decide that, or we determine that all cancer is genetic, but not all cancer is inherited. And what that really means is that cancer itself is just your body's own cells that have turned to grow and divide uncontrollably. And this sort of transformation where they grow and divide uncontrollably can be attributed often to mutations that occur in their DNA or in their genetic code. Now, these mutations can occur spontaneously or sporadically, or they can be inherited from a parent. But those inherited mutations only occur in about 5 to 10% of cancer cases. Now, when we think about tumor suppressor genes, this is the place that we tend to see these mutations in our genetic code. So these tumor suppressor genes are genes that we all have. In fact, we all have 2 copies of every single one of them. And when functioning normally, they should be protecting us from actually having cancer develop, because they should be slowing down our cell cycle and preventing them from progressing to quickly multiplying and forming cancer cells. Now, if you have a damaged copy of a tumor suppressor gene because of a mutation that might have arose sporadically, or it might have been inherited, it's like having a faulty brake in your car. So there's nothing really slowing this progression towards cancer. So when I say that all cancer is genetic, but not all cancer is hereditary, what I'm talking about is how these mutations arise in the tumor suppressor genes. In most instances of cancer, these tumor suppressor genes are spontaneously mutated, and that can be due to environmental exposures or lifestyle factors, things like smoking, things like UV or radiation exposure. Anything that can damage your DNA can knock out a tumor suppressor gene. But we tend to see that these cancers occur later in life because it takes a longer time for somebody to acquire 2 separate DNA damages in the same tumor suppressor gene in the same cell that would then turn cancerous. So for most people, we see these cancers in the 70s, 80s, et cetera, because this is happening by random chance. Alternatively, someone with an inherited mutation or a hereditary form of cancer is born with one of their tumor suppressor genes actually knocked out, not functioning from the time that they're born. And that's in every single cell of their body. They're down to their backup copy of the tumor suppressor. Now, they still have that one working, which is why they are not born with cancer, but they're far more likely to have a cancer occur in their lifespan because all it takes is one bout of damage, again, maybe due to something environmental or some sort of lifestyle exposure. Anything that can cause DNA damage risks knocking out that backup tumor suppressor, and that's when we see a cancer cell line develop. So identifying people who are born with a mutation in one of their 2 copies of a tumor suppressor gene is really critical in identifying who's at a really high risk of cancer versus who is not. Next slide, please. So thinking about hereditary cancer syndromes as just one of the many pieces of the puzzle of what can cause cancer is a really good way of framing this presentation. So I'll spend my time talking about these hereditary cancer syndromes, but I really want to frame that this only occurs in about 5 to 10% of patients, and that majority of cancer is actually sporadic, and it's usually attributed to increased risks from anything from diet factors, lifestyle factors, alcohol and tobacco use, environmental exposures, viral exposures like HPV or H. pylori that can cause cancer. Sometimes it's linked to hormonal use or medications, occupational exposures, and sometimes even ethnic background and family history can increase your risk of certain types of cancer. And so, like I said, this is one small piece of the puzzle, and these syndromes are quite rare. So finding these can be difficult, but if we can identify these families that are at risk, then we can help them. So that brings me to the importance of family history. So family history is ultimately the best tool at our disposal in order to find these families that have risk of inherited cancers. And so when we think about family history, not all families with a sense of cancer in them or an abundance of cancer in them are suspicious for hereditary cancer. There are particular clues that we think of. So one would be multiple generations of cancer. Do we see cancer running in parent, grandparent, grandchild? Or are we seeing this really just isolated in one person or one set of siblings? We also think about how old are the individuals who are getting cancer in a family? Because like I said, people with inherited mutations tend to see these cancers occur much younger in age than the general population would. So if you look at this family history that's on the slide here, notice that everybody has their cancers at a younger than average age. Almost everyone's been diagnosed with cancer under 50, with the exception of the one colon cancer that was diagnosed at 51, so right around that line. Cancer under 50 is usually the rule of thumb that we're looking for. Then we think about, is there anyone in the family who's had multiple types of cancer? And so if you look at this family history on the side and you look at the bottom corner, there's a daughter there that had both colon cancer and endometrial cancer. That is something that is suspicious to us when we see two separate diagnoses of cancer independent of each other. And what I mean by that is it's not the same cancer that's spread to a new organ, but it's actually two separate cancers popping up in the body. That can be an indication that somebody actually carries a mutation in all of the cells of their body that's making them at that higher likelihood to get cancer. And then we also take into account what patterns do we see in the types of cancer. So there are certain cancers that can cluster together. We know that colon cancer tends to cluster with uterine cancer in the Lynch syndrome 5 genes that can cause that. Or we can think about breast cancer as clustering with ovarian cancer, pancreatic cancer, prostate cancer, or melanoma. And so whenever we see those types of combinations, that raises our suspicion that there might be something inherited occurring in the family. And then lastly, we think about rare cancer types. So we know that breast cancer, prostate cancer, and colon cancer are 3 of the most common types of cancer we see in the general population. So seeing those in and of themselves is not really a cause for concern. But if we see things like ovarian cancer, as well as pancreatic cancer, no matter what age those are diagnosed at, we want to test because those are cancers that don't occur frequently in the general population. They are more rare. And if we do see them, we want to test because there also can be treatment implications. So why is this all important? Well, we know that individuals with hereditary cancer syndromes are at a significantly higher risk than the general population for certain types of cancer. And if we know about these cancer risks, we can personalize healthcare to lower cancer risk and maximize chances for a cure. So this might be through management and risk reduction options that include advanced surveillance or increased screening, or risk-reducing surgeries in order to lower risk. And genetic testing may clarify who is actually at risk in a family, as well as who is not at risk, and that can be equally as important. Identifying who carries this mutation lets us know who we need to screen, and being able to determine who doesn't carry it can give somebody a huge relief in terms of medical anxiety. So genetic testing is really the key there in terms of managing families' risk. Now, how these hereditary cancer conditions are inherited is actually in a dominant fashion. And so a common misconception is that these are carried more frequently in women, since a lot of them do impact breast or ovarian cancer risk, but that's actually false. None of these genes are actually on the X or Y chromosome, so they're not linked to a particular sex. They're equally transmitted by men versus women. Also, each person who carries a mutation has a 50% chance of passing it on to each child, because if we're thinking back to our tumor suppressor genes, they're born with a mutation in one of their 2 copies, and thus it's a 50-50 chance which one they pass on, the one with the mutation or the one without. And there are no skipped generations with this type of inheritance. So if you don't pass on the one with the mutation, then your family members are not at risk going forward. So who should actually have genetic testing? Well, the best practice is actually to test the family member who has the cancer diagnosis. We know that that's not always a possibility, so I'll kind of touch on that in a few slides. But ideally, we're testing all ovarian cancer patients, all pancreatic cancer patients, anyone with breast cancer diagnosed under 50, anyone with triple negative breast cancer, any breast cancer patient who has Ashkenazi Jewish ancestry, given that there is a higher carrier frequency for BRCA mutations in that population. We also think about male breast cancer patients as being particularly at risk, since this is a rare cancer in that group. Metastatic breast and prostate cancer patients are also eligible, since this can impact their current treatment. And then colon and endometrial cancer patients that are diagnosed under 50 are also concerning for us. Now, we do talk about age as being an important factor to consider. However, abundance of cancer is equally as important. So if we do see an abundance of cancer, even if they occur at older ages, you may still be eligible for testing. So for example, if there are 3 or more breast cancer diagnoses in a family, that can earn you the ability to test. Similarly, if we see breast cancer in combination with pancreatic or ovarian cancer, we definitely want to test. This is not an all-inclusive list, so please talk to a genetic counselor or a healthcare provider if you are interested in testing, and they can better assess whether you and your family meet criteria. Now, you may be sitting here saying, well, this is great, but I already had genetic testing, which is wonderful. But if you had genetic testing prior to 2013, then you may be due for updated testing. So back then, we were actually only looking at single genes because of the way that the technology was run. So you were probably just tested for the most likely gene that could have caused your type of cancer or your family history of cancer. And if that came back negative, it was left there. Since then, since 2013, we've actually developed technology that allows us to read through multiple genes simultaneously. So now, instead of testing someone with a history of breast cancer for just BRCA1 and 2, we might test you for 18 to 20 genes. So there could be a huge learning curve in terms of what we know about your family history from 2013 to now based on this updated technology. Also, if you had single syndrome testing, which was done a lot historically, but is not really done now, that means just looking for one specific cancer syndrome. So often it would be just looking for BRCA1 and 2 for a breast or ovarian cancer family, or just looking at Lynch syndrome for a colon or endometrial cancer family. If that testing was done on you and that was negative, come back, because we definitely know of many more cancer syndromes that can cause those types of cancers. And so there might be new testing available to you. And if you're unsure, again, reach out to your doctor, your oncologist, your genetic counselor. They'd be a good person to ask about whether updated testing might be right for you. So what if the affected family member is unavailable for genetic testing? This is not something that happens infrequently, especially since most of the time families with an abundance of cancer also have an abundance of loss. And so certainly the national guidelines recognize this, and they have put in provisions, especially making exceptions for individuals who have family history of cancer. So if anyone in your family had any of those indications I listed on that slide a couple slides ago, you would meet criteria because you have a relative who meets criteria. That's how this works. And so if we can't test the person with the cancer, don't let that stop you. We can still test you. But I will just caution you that what we run into if we test an unaffected relative, meaning someone who doesn't have cancer, we run the risk of getting an uninformative negative. And what that means is an unaffected individual has tested negative, and that becomes unclear whether it's because they've tested negative for a family mutation that could have caused cancer in their relative, or if the cancer is not hereditary at all in the family, or if there might be a mutation in an unknown or undiscovered or untested gene. And so for these reasons, it's ideal to test the affected individual if possible. If we test an unaffected individual, which we're happy to do, we just cannot rule out hereditary cancer risk in the family based on that person's results. So let's get into genetic testing itself. So what is genetic testing? Well, when we perform this type of genetic testing, specifically in hereditary cancer, what we're doing is actually doing a full read-through of selected genes in your genetic code. These genes are the tumor suppressor genes that I previously mentioned. And we're reading through to identify any errors or mutations that might alter the way this gene is expressed or functioning. Why would a patient choose to undergo this type of testing? Well, because it can be helpful in aiding with a current decision about treatment. So if somebody has an active cancer diagnosis, there could be targeted chemotherapies that are available if we can identify what's driving the cancer. Alternatively, it could help with managing future cancer risks and offering potentially risk-reducing surgeries for that management. And then lastly, it's beneficial for family members to know what might have caused the cancers in the family. And like I said, we can use this to determine who is at risk in the family and who is not. Testing is usually done on a blood or a saliva sample. And in terms of insurance coverage, which I'm asked about a lot, insurance actually does provide a great deal of coverage for genetic testing, especially when deemed medically necessary. However, even if your insurance does not pay for testing, a lot of the commercial labs that we use have been making efforts to make this testing a lot more accessible to the average person. So there is discounted out-of-pocket prices if you don't get insurance coverage. Currently, right now, the maximum you would pay for this type of testing is about $250, regardless of how many genes you look at. So for the genetic test itself, the best way I can describe it to you is if you think about your genetic code as the instruction manual for how your body is built, you can think about each page of the manual as a specific gene. And so these tumor suppressors, they each get their own page in this manual. When we do this type of testing, we're reading through those specific pages to look for any spelling mistakes, any extra words, any missing words, anything that would take away from your ability to interpret the instructions. If there is something on that page that takes away from your ability to interpret the instructions, that's analogous to finding a mutation in your gene that stops that gene from functioning. And so why I highlight this in such detail is because I want to emphasize that these specific mutations in genes are often unique to a particular family. And so it's not enough if you're trying to look for testing for yourself for a known family mutation to come into an office and say, my family member has a BRCA mutation, because we really do need to know, well, where on that specific page is the mutation to ensure that we're not missing it when we go to test you. And while it is a small chance of error that we wouldn't pick up the mutation, sometimes different labs use different technology. And so we really want to make sure we know where we're looking, we know what's caused this cancer in the family, and we want to find it or not find it in you. And so ask your relatives for a copy of their genetic test report before you go in to meet with a genetics provider. That can be crucial. So there are three types of possible genetic test results that you can get. The first is a positive result, meaning that the lab has read through the gene and they see a mutation in it that is harmful. And in this situation, it would cause an increased risk of cancer. For these cases, this is when we would proceed with testing relatives, and we might also start recommending changes in care. If we find a negative result, that means that the lab has read through the gene entirely and they didn't find any spelling mistakes or any additions or duplications to what they should have found. So when we have a negative result, it can be for two reasons. It can either be a true negative, meaning that we know what's caused the cancer in the family and this person does not have that, which is the best possible news I can give, because we can really then say you're probably at the general population's level of risk and you can just screen like the average person would. And so that would be annual mammograms instead of thinking about mammograms and breast MRIs and doing it every 6 months. So it can really be a release of a burden for a lot of relatives. Alternatively, the uninformative negative is what we discussed previously, where we're testing an unaffected individual, someone without a history of cancer, and they test negative. So we don't have a way of actually ruling out hereditary cancer risk in the family. The last type of result that I want to mention here is something called a variant of uncertain significance. What that means is that the lab takes a look, they read through the gene, and they see a change in it, but they're not sure if that's a harmful mutation that could cause cancer, or if that's just typical human variation that makes you different from me and the next person. And when they find these, they identify them on the report, and that's almost a flag to say, we're not sure yet, but we're going to keep looking at it. And I will say, when we do get variants of uncertain significance, we don't act on them. We don't start changing your care or recommending any medical management changes, whether it is just screening or doing some kind of preventative surgery. And the reason for that is because 80 to 90% of these get downgraded to benign or a negative result. And the best analogy I can give for these is thinking about the word gray. If you think about the word spelled G-R-E-Y and the word spelled G-R-A-Y, both gray and gray refer to the color gray, and it doesn't change the meaning of the word. However, if we actually are thinking about these variants of uncertain significance like that, that means that most of the time, these are small little changes in your genetic code that just make you unique and actually don't alter at all any function of your genes. So because most of the time this is what it is, we wait and see. And if the lab upgrades it to a positive result, then we would recontact you and let you know it's time to start changing your care. So there are different types of genetic testing that are available, and this is something that would be reviewed with you if you went to meet with a genetic counselor. You'd get to ultimately decide what type of testing is right for you. Now, single gene testing is historically how testing was done. This is where we look at one gene, the most likely culprit to have caused this pattern of cancer in the family. And now, because of the way that testing is done, and it's actually a lot more affordable to just test a bunch of genes together, this isn't done as often, but it is still done if there's a known family mutation, meaning we know what's caused cancers in the relatives, and now we're testing this person for the exact same mutation. The pro of doing this kind of single gene approach is that it minimizes the chances of getting uncertain information, like those variants of uncertain significance. So it has the potential to kind of minimize anxiety. The con, however, is that we are potentially missing inherited mutations from the other side of the family or in other genes that we haven't tested. Alternatively, since 2013, multi-gene panel testing has become increasingly popular. So this newer technology allows us to simultaneously read through multiple genes at the same time, so we can test for multiple hereditary cancer syndromes at the same time. At a lot of these labs, we can actually customize what genes we look at. So we can really tailor this to what does your personal history reflect and what does your family history reflect, and keep it just narrow to those types of cancers. Or we can cast a large net and just scope out everything we know in cancer genetics right now. Both of those are equally comparable in terms of their cost. So that's actually one of the pros of multi-gene panel testing, is it's less expensive than the single gene approach. It takes less time. And if we're doing a broader search, then we're more likely to find the responsible gene. However, we open ourselves up to more uncertainty. And so that would be the large con here, is that we're more likely to find variants of uncertain significance. We're also more likely to find something in a newer or less well understood gene if we keep testing broader. And so that can sometimes provide challenges in determining what healthcare providers should do to manage you going forward and manage these cancer risks, especially if there aren't published national guidelines for that gene mutation. Now, one more thing I kind of urge you to think about as you proceed with testing, if you think this is right for you, is kind of a caution against doing at-home DNA testing. And what I mean by that is there's a number of direct-to-consumer companies that have arose in the past few years, and they've become popular because of their ancestry testing. But recently, they have received FDA approval to provide medical information and give certain information about genetic health risk. And so a lot of them are advertising that they can tell you about your hereditary cancer risk. But I want to caution you against using this for medical information, because the way that this testing is done is different than the way that we do this from a medical perspective. So we do a full read through of these genes. A lot of these companies are just looking for common mutation sites in the gene, and so they're not doing a full sweep, and it's potentially offering you false reassurance if they give you a false negative. So I'd stay away from those. I will provide resources at the end to get you connected with a genetic counselor, and that's sort of the ideal way to get tested if you're trying to use this information for medical management. And then something I'm asked about quite frequently is the Genetic Information Non-Discrimination Act. So that did get put in place in 2008, and it is a federal law prohibiting discrimination by health insurance companies and employers on the basis of genetic information. There are certain exceptions. So this does not apply to life insurance, disability insurance, or long-term care insurance. And it doesn't apply to people who receive care through TRICARE or people who receive federal support for health insurance. So there are specific exceptions, and I would urge you to kind of look into this before you proceed with testing. If you would like to take out a life insurance or disability or long-term care policy, I'd do so before you get your testing. And if you want more information on this and what's covered and what's not, go to www.ginahelp.org for that. So say you do proceed with testing and now you have a positive result. Now what? Well, positive test results actually yield medical management changes. That's the whole goal here, is to make sure that this is actionable. So once a patient has tested positive, our main goal becomes, what's the best approach for treating their current cancer? And that might mean using a targeted chemotherapy now that we know what's driving the cancer, like a PARP inhibitor in any kind of BRCA-driven cancers. This would be something to ask your oncologist about if you do test positive. The second goal is thinking about preventing future cancers or catching them early. And so this might mean adding a breast MRI in addition to the annual mammogram, spacing them out every 6 months. That way we're kind of keeping a closer watch of, say, breast tissue, if that's where the risk was. Similarly, if it was colon cancer risk, we could potentially shunt the colonoscopy interval so it's closer together, potentially every year or every 2 years instead of every 10. Alternatively, we can offer risk-reducing strategies like preventative surgeries, especially in instances where we don't yet have great screening. So ovarian cancer is the prime example. We don't have great screening for ovarian cancer, and preventative removal of the ovaries dramatically reduces risk of ovarian cancer. So we do recommend that to patients, especially postmenopausal women who test positive for an ovarian cancer risk gene. But all of these recommendations would be tailored based on whatever gene actually comes back positive. And then lastly, we want to use this information to help your families. So start spreading this amongst your family members and make sure that those individuals are getting in, getting tested, and getting on top of their risks as well. There are national guidelines in place for screening and prevention options. And like I said, that's tailored to the specific gene because not all genes confer the same level of risk. So it's really, really specific to the family when we actually do identify these. And then ultimately, getting connected with a genetic specialist is ideal to learn about your options for cancer prevention and early detection. So I'd recommend seeing a medical geneticist or an oncologist that specializes in genetics. And if you're looking for how to do so, so these are the resources I've highlighted here. So these are good ways to either get genetic testing or to actually be followed up on if you have a positive test result. So you can screenshot this slide. The top corner, nsgc.org, that's the National Society of Genetic Counseling's website. They have a wonderful Find a Genetic Counselor tool on their homepage. So you can put in your zip code and the specialty that you're looking for, in this case, cancer, and you'd be able to find a genetic counselor local to you. Alternatively, if you're looking to get your relatives who might live scattered across the country in touch with a genetic counseling program, Penn Medicine does have a telegenetics program that's licensed in every state outside of PA and New Jersey, so they can see patients for virtual genetic testing appointments. So you can call that number there. Christiana Care is local. It's in Wilmington, Delaware. They have a cancer genetics program as well, so they're able to provide genetic counseling, order tests, as well as follow up on positive results. We can also do that at Penn Medicine if you're willing to drive a little bit further. You can be seen in the cancer risk evaluation program by calling the number in the bottom right corner. And I'll give it one more minute so you can take down these numbers. Okay. So finally, to summarize everything, and so if you don't get anything, please just pay attention to this slide. Most cancer is not hereditary. Only 5 to 10% of cancer is. So this really is speaking to a smaller subset of the cancer population. However, if we do identify these cancer risks, it's really, really important because these individuals are at such a higher risk of cancer. So I'd urge you to ask your relatives about your cancer history in the family, because that's the best tool for us in identifying inherited cancer risk. I would urge you to ask these 3 questions. Ask about the age of diagnosis, who's had cancer in the family, and what kinds of cancer have they had. Like I said, these individual families are eligible for increased surveillance or risk-reducing procedures, so it's really important to get this information out there. And if you do test positive, please share it with your at-risk relatives. Far too often, we're seeing individuals come in after the fact with a new diagnosis, and it's just because this information was never really conveyed to them by family members. So please spread that. And then also, genetic testing is available and is most often covered by insurance. So don't let costs be prohibitive. Meet with a genetic counselor. They'll be able to tell you whether you meet criteria or not. And if you do have to self-pay, like I said, a lot of labs are working to make this much more affordable now. And then lastly, cancer genetics is a rapidly evolving field. We have progressed so much in the last 10 years, and in the next 10, who knows where we'll be. So genetic counselors are ultimately the best place to go to for information. we're the type of people that would be determining what type of testing is most appropriate for you, and we can help you make those decisions. And then ultimately, we can kind of let you know what's up and coming down the pipeline. So thank you so much for joining me this afternoon. That's all I have for you, but I'm able to take questions if there are any.
Great. So feel free to put any questions in the chat.